All right, so our procedure that we're presenting on is a thyroidectomy, which is the surgical removal of the thyroid gland, sparing the parathyroid glands. So reasons that you may need this surgery include hyperthyroidism, which is the overproduction of hormones by the thyroid gland, thyroid nodules, which is a condition where lumps are formed in the thyroid gland, a small percentage of which are cancerous, which would lead to thyroid carcinoma, a type of cancer that develops in the cells of the thyroid gland. So for this procedure, the patient is in supine position with their head aligned with their spine and a rolled towel placed between the scapula to slightly hyperextend the neck. Some surgeons prefer the reverse Trendelenburg, at which point you would add a padded footboard on the OR table.
Okay, so I will be going over draping, skin prep, and parts of anatomy that could be identified during a thyroidectomy. So for the prep boundaries, it's going to be done from the point of the chin to mid-chest and bilaterally as far as possible, following the jawline to include the entire neck and shoulders. Draping will start with 4 surgical towels used to square off the incision site. The upper towel will be placed along the chin, the lower towel will be placed at the clavicles, and the 2 side towels will be placed along the side of the neck using the sternal ends of the clavicle as landmarks. Drapes can include a transverse drape, a thyroid drape with a transverse opening, a split sheet with head drape, and a head and neck drape. Which one you use will depend on the preference of the surgeon that you're working with that particular day. And then different types of anatomy that could be identified during a thyroidectomy are going to include your parathyroid glands, your inferior thyroid artery, the recurrent laryngeal nerve, and the trachea. All of these can be identified throughout a thyroidectomy.
All right, the brief steps for a thyroidectomy are: 1, a transverse incision is made over the thyroid, typically 1.5 to 3 inches long. 2, superior and inferior flaps are mobilized and retractors are placed. 3, the thyroid is exposed by incising the fascia between the strap muscles. 4, the superior poles are retracted with Leahy thyroid clamps, and the tissue between the trachea and superior poles is dissected with Metzenbaum scissors. 5, the parathyroid gland and inferior thyroid arteries are identified, mobilized, and preserved. 6, branches of the inferior thyroid artery that do not supply the parathyroid glands are clamped, divided, and ligated. 7, the thyroid is elevated and dissected from the trachea. And 8, the platysma muscle is reapproximated and then the skin is closed. And the 3 examples of equipment and supplies that may be needed for this procedure are unique to the thyroidectomy are cotton tip applicators, drain, which is usually of surgeon's choice or by availability, a harmonic scalpel or ligature, nerve stimulator, and fine or delicate hemostat, since it's such a small area. Risk factors that are involved with a thyroidectomy are your typical hemorrhage, surgical site infections, tetany, which is caused by a malfunction of the parathyroid gland, which is why they try to at least leave 1 parathyroid gland. And an emergency tracheotomy may be needed if there are any complications that may affect the patient's airway. And so our question for you is, what are the Metzenbaum scissors used for in this procedure?